So there are some preclinical evidence and some clinical evidences that the biology of melanoma is different for BRAF mutated versus not mutated patients. And this is true for a patient with limited disease. There are some reports showing that there are more recurrences or more risk of recurrence in patients with BRAF mutated patients when we adjust for stage. And similarly for the advanced disease, there are some clinical data suggesting that patients with BRAF mutation have ultimately a more aggressive disease. However, when we put in most of the study the BRAF mutation and adjust the BRAF mutation with all the well-known prognostic factors, the role of BRAF mutation is open for further investigation. So at the moment, the presence of BRAF mutation or not in advanced disease is important to make a therapeutic choice, and it's a predictive factors for target agents, but cannot be strictly and definitely considered as a prognostic factor when adjusted with other prognostic factors such as the AGCC stage and the level of LDH, or with the new classification of the presence of brain metastasis. But of sure, the presence of BRAF mutation may be important because there are some preliminary clinical data showing that some specific immunotherapeutic strategy may work differently in patients with BRAF mutation versus BRAF wild type, but these are only preliminary data, and I think that we need ad hoc studies just to confirm this. So at the moment, the presence of BRAF mutation is important to make a choice for a therapeutic strategy, and there are some preliminary data showing that this may be a marker, a more aggressive disease, but I think that we need more solid data to confirm this.
BRAF mutation is not prognostic factor for metastatic disease. LDH level, site of disease, and the number of metastatic sites are the more important prognostic factor together with the symptom related to disease, so the personal status of the patient, the performance status of the patient. These are the factors discriminating the prognosis of the patient, both in mutated metastatic melanoma and non-mutated metastatic melanoma. So there are aggressive behavior of melanoma also in non-BRAF patient. And the decision of the treatment is based on this aspect and the presence or not of the mutation, but we can say he has a BRAF mutated melanoma, so he has an aggressive disease. It's not that.
Most doctors tended to treat the most aggressive tumors, BRAF mutated, by BRAF MEK inhibition, and keep the less aggressive disease to introduce them in the immunotherapy trials. So it's possible that some of the prognostic issues that were discussed linked to BRAF inhibition, BRAF mutation, were in fact just a bias tending to enroll patients with less aggressive disease in immunotherapy and those with more aggressive disease in the BRAF plus MEK trials. So that could be a bias explaining that kind of debate, but I think, as my colleagues say, BRAF mutation per se is not a prognostic factor.
In immunotherapy clinical trials, which included also patients with BRAF mutation, the percentage of patients that have been included in this trial is about 30%, and we know that the percent of BRAF mutated patients in the general population is more than 40%, between 40 and 50%. So there is an underrepresentation of patients with BRAF mutation. And in some specific clinical studies, such as the Keynote-006, patients with high LDH or symptomatic patients with BRAF mutation have been excluded to be treated with the immunotherapy unless they received previously BRAF or BRAF and MEK inhibitors. So there is also a selection of this patient, and this can influence the outcome and the interpretation of the data, and ultimately the implementation of the data we have into routine.